Okay, welcome.
Sure. Yeah, like you say I had lots of experience of treating Mr. Wernham, like various of my colleagues, that were undergraduate with him. Um, and that would always be like scary as you can imagine. Um, just the fact that, he was such a figure and could be quite intimidating, even just the size of him. Um, as undergraduate students, we'll be treating him and anything going he didn't approve of, he'd leap up off the table and start having a go at you and so on. But it was when things came full circuit and we ended up working postgraduate with Mr. Wernham that things got really interesting. He was in his later 90s at that stage. And there was one point where he'd gotten ill. Very often it was overwork that was taking him down. He worked so hard, right till the last what possible, kind of minute. Um, and he got himself run down. He was tired. He was revealing kind of like neuralgic pain, and like we teach in the class, he said that it was actually coming from liver. It was a referred thing from the liver, and I said, where do you think that's come from? And he said, well, he'd had malaria in the war. He was a photographer in the North Africa campaign, so they were busy hanging around Africa and got malaria. And he said if he was ever significantly run down, it would, the symptoms would start playing back. And of course, this neuralgic thing was coming up from the liver. That
Across
sort of
his
refer.
face,
Yeah, yeah.
just because the podcast is being played on Spotify and Apple and Android, so people won't see you touching your face
Right,
unless
right, right.
in YouTube. But for the viewer's sake, Chris is touching across his face along the maxilla, along the facial nerve, trigeminal nerve.
Yeah, yeah. So anyway, I started treating him. He then went into sort of a bit of a kind of healing crisis and really kind of was exhausted. And I treated him at home. And this is where it really kind of got interesting and somewhat scary because one of the things that we look at osteopathically is how symptomatology, how the sort of physiology of the body is manifest on the surface. So, like I was just referring to the trigeminal nerve kind of referral. So, I was treating him, and the area over the heart, so the ribs 3 to 5, or 3 to 4, 4 to 5, was distinctly cold. And one of the things that we talk about is like, coldness on the surface of the body reflecting a congestion deep within. And, working with him, I got to the idea that, what was going on with him was a congestive heart failure kind of condition. So I was working really carefully, obviously, and trying to sort of stimulate a response, get the circulation moving. I'd read up on, what Little John's perspective on congestive heart failure was. And the first thing, funnily enough, is just to, start like you would with the body adjustment, getting the peripheral circulation opened up to reduce the resistance to the heart itself. So you're easing the heart's sort of, resistance. So obviously I began in that way and was working with him. And then we get to our cranial bit. So, worked all the way up through to his head, decompressed, and started doing we talk about in terms of vertex inhibition, which is a point very often in the treatment where we go from kind of more of a sympathetic kind of dominance in the body to a parasympathetic. So a patient very often at that point will start sighing, or their breathing patterns change. You hear the gut start gurgling as the borborygmi kicks in and so on. Anyway, I started doing that with him and I got sort of halfway through and he stops breathing. He stopped breathing, and I'm going, oh my goodness, I'm going to be the person that was famous for killing Mr. Wernham. And I carried on, and he took this enormously sort of like very quiet but deep breath
Oh, wow.
and sighed, and then his breathing just calmed down, his whole kind of, demeanor calmed down, and he got into the sort of more parasympathetic ease, and that point, just scared the living daylights out of me as I was working because he literally, I don't know how long he'd stopped breathing for, but it was enough to be like is he alive? Is he gone? Anyway, so one of the things that got me, as a sort of career thing, in my life was the response to that. Because 2 days later, he came into the college. I'd perceived him as being on death's door, and then like couple of days later, he comes into the college, not to work. He just wanted to be there, to be present, and also like he was going to just sit in the sunshine and recover, as it were. And I looked up at him, and because he was coming down some stairs, I looked up at him and said to him, "Good, my goodness, you're looking a lot better." And he looks to me in this sort of wise old man way, and he goes, "Don't sound so surprised, my dear boy." And that
How
was that was that was quite a sort of like, I don't know, quite an inspiration to my the rest of my career that, A, that I'd been able to help him, but B, that it was like his response was, don't sound so surprised. This is what osteopathy is. This is what it does.
how deep into your career were you at that point, Chris?
Oh, so that would have been mid 2000s, 2005, I'm guessing. Um, he passed in 2007.
Mm,
So yeah, I would think that. So I'd been out of college since 89.
yeah.
So
Oh
it
God, it's
was
quite a while.
yeah, yeah.
Had you ever had that experience with a patient like that before, or?
Not in that way. I had treated
Yeah.
people with an old friend of our family with congestive heart failure, and again, an astonishing response.
Mm,
Even people that have some idea of the kind of scope of osteopathy don't always have a full sense of how responsive a human body can be. Especially, digestive problems, especially with babies,
mm,
heart problems. I've had, people with all sorts of different conditions, remarkably improve, and some, very short term, kind of really astounding responses that people are really suffering, and then, you run through some treatment, and then they're up and about and absolutely fine. And it's oh my goodness, that was osteopathy. And yet, you can read it in all the history books, but there's little evidence. We have one kind of like, sheet of evidence from one of the periods of time from the early 20th century, no, the late 19th century, where one of the hospitals, Washington Hospital, has a record of the kind of treatments that were given, the kind of conditions that they were dealing with, and so on. But there's so little evidence of what the early osteopaths actually achieved. You're
mm.
looking, you're looking quizzical.
I did. I know. Sorry, the record button looked weird to me again. Can I ask a question at this point?
Of course.
So I'm going to keep it to Mr. Wernham if that's okay, because it's a tissue quality question. So you would have treated Mr. Wernham more than once, and
Yeah.
throughout your career, and Mr. Wernham is different ages at this stage. I don't know where my question's going. I want to understand um, how the tissue quality would have felt at that point where you were treating him and he stopped breathing, just to kind of educate my own palpatory library in a way. Like how did he feel while you were going through and then that reaction happened? And then how did he feel the next time you laid hands on him again osteopathically?
Um, there wasn't major indicators other than the sort of clinical indication of the local manifestation over the heart area. And it was very distinctly cold. When it's a clinical kind of sign, it's very
Mm,
localized and very specific. It's not like a kind of, half the body is cold or, a sort of
mm,
region. It can be very localized to one or two vertebra or, intercostal space. If you're treating somebody with a gastritis, it will be right over the stomach, even though it's not the stomach that's throwing out heat. It's a trophic kind of response.
mm,
But the circulatory thing can either be, a direct circulation phenomena, i.e., if the circulation is congested deep, there's no blood to be on the surface because you're draining, off a common branch of an artery. So, like, when the pelvic organs are massively congested, the gluteal sort of tissues will be cold. And that's
Hmm.
partly just reciprocal circulation. So the blood is like come off that branch and it can't go off that branch. So, but with Wernham, there wasn't a great kind of indication other than that. And when I was doing the sort of vertex inhibition, it just hit that, some osteopaths talk about a still point in different aspects of osteopathy. It was that kind of phenomena where, his whole system just kind of paused, like you turn the computer on and off again if it's struggling, or switch the internet on and off again. It was almost like that. It was just like that kind of still point and then off, back into a softer sort of gentle rhythm. But it was such a prolonged sort of period that it was quite shocking. But otherwise, it wasn't a great deal to say in terms of sort of palpatory stuff. Um, he had in spite of his age, right up until the last minute, he had a strong vitality. He knew how to look after himself, and he knew, kind of the principles of life, if you if you like,
Yeah.
you know.
Chris Campbell says this wonderful thing that I like about an osteopathic body, and it's training a body to receive osteopathic treatment, and the body starts to respond when it knows it's getting osteopathic treatment.
Yes.
So, I imagine Mr. Wernham's body was very receptive to osteopathic treatment, having had it for most of his life.
Yes and no. He hadn't had a massive amount of treatment because
Ah,
he
okay.
yeah, yeah. It wasn't like, his patients that he would have a treatment like on a, weekly basis or whatever. He just had bits of treatment when he needed them off students, like give me a leg tug or do the side roll. Unless he knew somebody, knew what they were doing was to come in, like Mervyn came in. I've got like footage somewhere of Mervyn treating Mr. Wernham and vice versa, I think. So Wernham wouldn't necessarily have had lots and lots of treatment, but he knew what was going on enough to be a really good patient. He would submit, and whatever you were doing, he would go along with it. Apart from when we were undergraduate students, and he was, very much in the role of teacher as well as, being the patient on the table, because he didn't want you to do stuff that was like clearly wrong, like the leg tug business.
Yeah.
Or the side roll, and literally he would get up off the table in his underpants and then, talk you through it. Bizarrely intimidating kind of process.
A passionate teacher, though. Um,
Oh, totally.
I have to retract my question then, because my question was, how would a body that's not being treated osteopathically respond in similar ways, or does the body need to be prepped until it gets to that point where it can come to a point of release? That was what my original question was going to be, but
Yeah, well, that's a lot to do with practitionership, also the state of the patient and their willingness. Patients will lie there resisting treatment, helping treatment. They'll be wobbling their arms and legs ahead of
Mhm.
you, and so on. When somebody is acutely ill, their body is amazingly receptive, particularly with kids. Particularly with kids, and the younger the kids, the more receptive they are, and the more delicate the process has to be. I've treated a couple of kids like my own kids and like friends' kids just because I was there, treated them through fevers and stuff, and the kind of contact and pressure is absolutely minimal. It's soft and absolutely minimal. And then you back off again. It's Still's kind of principle, like find it, fix it, and leave it alone. You just engage with it, make sure that you've kind of, made that point, and then back away again, and not keep on trying to do something,
Yes, yeah,
follow the body's own sort of, kind of intuition, if you like.
yeah, no, no, I totally get that. also speaks volumes of our own experiences as well, because, you said that moment was so frightening, not something you've experienced before. And I'm sure we've all had a moment in practice where we've been a little bit like, oh God, what's going on here? And you have to kind of come out of that moment of shock, reflect on your principles, and deal with it in the moment. Not all of us have the confidence to get to that point in the first place because we're not really capable that we are able to.
Yeah, yeah. I mean, that's one
Serious
of the things that,
education there.
we try and instill with the institute's courses is, the kind of scope of osteopathy, the real scope of it, where it kind of originated from, but also, that like my own interactions with people over the years, it's been very, very careful. It's been with that sort of priority of the patient's safety, but equally with the principles behind you, with an understanding of, what we refer to as osteopathic centers, so how we interact with the nervous system and so on. You can pretty much always find something that relates to the symptomatology in the sort of spinal configuration in the body's manifestation, rib displacement, fluid mechanics. There's always something to read. There's always something to attend to. And when you get to sort of the realms of sort of like acute ailments, then you're working with delicacy and with such gentleness that the sort of chance of error is much 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 diminished. That you go in cautiously. It's easier to sort of go in and back off to see if anything's happening than just to keep doing. And that's the way it has to be with those kind of situations. Priority of safety, priority of the patient's comfort and care.
Just for listeners who may not be aware of the Institute of Classical Osteopathy, run a diploma course that lasts 18 months and they go through these principles which Chris is talking about and really helps to integrate your osteopathic understanding with the patient before you. So it's very comprehensive. Definitely recommend checking that out to our website. If you don't know it, it's classical-osteopathy.org, but that'll be in the show notes. No, you're right, Chris, because listening to you saying what you've just said reminds me, and I respect it was a very long time ago, how I felt when I was studying osteopathy to how I felt being part of the ICO journey for such a long time. I remember being at the BSO and thinking, well, how did Dr. Taylor Still treat his kids for meningitis? And I'm nowhere near that. I'm nowhere near that. I can't even do just like skin conditions or basic hay fever or anything. I was nowhere near that. And a lot of my journey, I've done the diploma course, I've helped out at the course, I've been immersed around teachers like yourself, and with time, with experience, with learning through lectures and webinars and talking to you guys directly. Um, and my confidence has grown. One, to trust myself as an osteopath, but also just listen to the body and exactly as you're saying, just find that point that needs to kind of be addressed in the equation that I might have overlooked because it's not something that I might have overlooked.
Yeah, yeah. Also,
Mhm.
there's certain kind of key principles about treatment. If you read through enough of like Little John's practice notes, that you get an understanding of, particularly with the sort of stimulation inhibition side of things, that there were patterns, there were patterns that became when you watch ER or one of these TV programs, you get to hear certain sort of like, pharmaceutical usage in particular emergencies, like, the cortisone or whatever, sort of these emergency measures. We have the same in osteopathy.
Mm.
Very often if there's an inflammatory or painful or grossly disturbed sort of circulatory pattern, we offer inhibition, so it's pressure sort of paraspinally from the second thoracic to the second lumbar to try and come in through the sympathetic system. And it's startling how responsive the body can be to stuff like that. Just give you an example. I've 4 times, 5 times been in the situation where somebody has gone into convulsions. So a couple of times it was people I knew who were going into epileptic fits. Um, and one time I was asked to treat a child that was on the early stages of developing epilepsy,
Hmm.
and was very nervous. So she was starting to go into a fit. And my own daughter, she had an infantile convulsion at one point. And for each of those occasions, I offered like fairly strong like inhibition from the second thoracic to the second lumbar, and then very strong suboccipital inhibition, and then backed off. And in every case, it aborted the fit. It's like it didn't cure anything, but it aborted the fit. And it was just such simple measures. It took what, a minute,
Mm.
and yet, profound effect in terms of dousing, what can be sort of, quite a harmful process, or, you know, somebody could injure themselves,
Hmm.
etc.
Hmm. That is so powerful, Chris.
Yeah, and it's simple. It's so simple. There are certain kind of procedures like that we can bring about just as a sort of like introduction to whatever that kind of condition happens to be.
Mm.
Sometimes you'll go in and you'll do a lymph pump to help clean things up, in some sort of acute situation or in some sort of very chronic situation. So somebody has like a painful arthritis or something, you might begin a palliative treatment with some lymphatic treatment.
Mm.
And the same with kids. A lot of the time with my own kids, I would do, they were going through something and it wasn't sort of like desperately clear, didn't look terribly, threatening, but, just running through like a little lymph pump on them, just change the whole sort of system's dynamics.
I love a good lymphatic treatment.
Yeah, yeah. It can be magical when you really need it.
Oh, the lymphatics book is probably one of my favorite anatomy books. I've read that a couple of times. I remember I sent you a screenshot of it once, didn't I? When there was a image of doing lymphatic drainage around the eye orbital, and I went,
They really do that though. Do they really like?
they really did. Yeah, they're great. Can I ask you to talk about one of your most rewarding case histories, if you have one that you can kind of go into?
Yeah, there's numerous. Sometimes it's where you would get a response that you're just totally not expecting. I've got a case history of a guy that I was trying to treat for digestive problems. His wife had been a patient of mine, and um, she started to talk about her husband's problems. He had like diverticulitis, etc., etc., etc. And I started treating him, and I said to her, like, please, like, if he's happy to do so, bring him in and I'll use him as a case history and I'll really carefully recall what was going on. And she took pictures at each stage and so on. And we got through the process, maybe a month into treatment, and his guts would be fine. He had no symptoms for ages. He went back to go to work, and he worked as a naval helicopter pilot. And by the nature of their job, they have very thorough medicals. They have to because they're so responsible for people's lives very significantly. He was also training people to be helicopter pilots, so double responsibility. Anyway, so we get to hear that his digestive problems are sorted, that he's able to go back to work, and in the meantime, the doctors find out that some anomalous condition of his heart, which was subclinical, he had a right bundle branch block, they call it. Some of the transmission issues, in the heart itself, and this had disappeared. And there was this bizarre letter, I show you the letter from the medic saying, well, we don't know what's happened, and we assume it's still the right patient because this record shows something, something. But this underlying condition has disappeared, and we just don't know why or how. So, well, that's osteopathy. And I wasn't like focusing on that at all. He'd mentioned it initially, but it hadn't even sort of gone in. It's like some underlying congenital heart thing, I'm thinking. And it, just undoes itself and resolves itself. So that was one of the cases that has most affected me over the years, though, was quite early in practice. I had a little kid. Now, I was a friend of the family's. A lot of interesting cases don't come like off the street, as it were. They're friends of friends, or kids, or your own kids, or your own family, and so on, where the most kind of interesting stuff is in some circumstances. Until patients get to hear about what you do, and then they come in. But this was so I was friendly with a family, and we were going out for a walk with the kids, and one of the kids clearly wasn't walking very well. His feet were turned inwards, and when he started to run, he would literally fall over his own feet. He would fall over, he would trip up over his own feet. So I spoke to the mother, who was a friend of this friend of mine, and I said, I'm working as an osteopath, if you might be interested in some treatment, blah, blah. And she took me up on it straight away. She worked as a nurse. And I would do a home visit, like a house call, on the way back on the way back home. So, sort of in the evening time. So he was already like in his pajamas and ready to go to bed. Quite often he would fall asleep in the middle of treatment, and I would just manhandle him, turn him over and stuff, and he'd stay asleep. Um, in those days, I didn't really know quite how to do such an integrated treatment. So I would run through the body adjustment each time, but one treatment I would concentrate on releasing the bowel, like a bit of gentle visceral technique. And then another time I would be a much more mechanically based treatment to try and level off the pelvis and integrate, different centers in the spine. Obviously, at the stage I'm at now, it would be much more of an integrated thing. It wouldn't be separate kind of treatment protocols. This treatment went on and off for several months. So not only did he have like internally rotated legs, his pelvis was kind of, inflaring both sides to some degree as well. And he had like the most desperately chronic constipation, which is obviously like a major, significant factor in small kids. So I didn't really get to hear much about the constipation because, or even see him walk. I just had what the mother was telling me. So after maybe 3 weeks, 3 months, sorry, of treatment, very on and off, wasn't every week. I went for a walk with the family again, and it, the kid's bowel had recovered, and he was doing his thing on a regular basis. Um, And like the mother had said that the walking had improved, and then say walking with the family, got to see this child running with the other kids, and that just really like drove something home to me with kind of dealing with kids, that how significant just that phenomenon was. The fact that this child was able to run with other children, never mind the fact that heaven knows what would happen with his intestine. As I say, he was pooping like maybe once every 8 or 9 days or something. So his system was like in a really bad shape, and not functioning well. And of course, on laxatives or whatever medical treatment still wasn't working. And they were talking about doing some sort of operation on the bowel. And I'm thinking like, heaven forbid, and what just that simple interaction did for that child. And as I say, it's never about, egotism. It's not like, oh, look what I've done, because you don't do it in the sense of like you're not mending people like a car or something. You're just freeing up the body's own mechanisms. And sometimes they pick it up and sometimes they don't. So it's not like you can wave this magic wand and all of a sudden, people start sort of becoming all sort of jolly and healthy again. Anyway, that was in many ways one of my most kind of happy moments in treatment, and it was quite early on. Otherwise, I think it was also at that same kind of era, treating a lot of kids with asthma. I'd had asthma as a child and realized, like, how much it can sort of set you back. When I was a kid, we had a driveway that was like about 45 degrees, not quite, but pretty steep. And I couldn't make it to the top of it sometimes as a little kid. I would struggle to sort of get the breath to sort of walk up to the top of this thing. Um, so I was really interested in helping out kids in my early sort of stages of practice. So I would be now if they
Mm.
came in. And the point being, with osteopathy, with the small kids, that the condition was resolved. There was no more asthma. It wasn't like it was a bit easier or, a bit of relief. It was gone, you
Mm.
know. That's what osteopathy does.
That's why I got into osteopathy by being treated as a child by an osteopath for my asthma. I still have it.
I think the
I'm sorry, I shouldn't have thrown that joke in. I do still have it, but I could run the sports day 500, is it a relay? Is that what they call it? We pass the baton thing?
yeah,
And the 100-meter sprint. My sport PE teachers commented on just how I can now run it without needing my inhalers halfway through.
stop halfway.
I had to stop completely. It used to be that bad. But
Yeah.
that's what got me into osteopathy. Wow. Would you like to speak about any more of your case histories that kind of hung around with you?
Um, yeah, when there was loads over the years. There's ones I like to bring up in the class that sort of make a point, as it were, make a teaching point. Like there was a guy that I treated, he was in his 50s, I would say. He came in for treatment and he describes to me like a massive pain in his arm down into his hand. Describes, very specifically kind of dermatomal distribution. And he has no arm, he has no hand. So it's a phantom limb pain. But clearly, like he's describing a specific kind of nerve distribution, et cetera, et cetera. And I started treating him as with many kind of conditions with no idea that if I could do anything. He'd had the problem for 20 something years. He'd fallen onto a train track and the train had lopped his arm off, and it was beyond saving. Um, and clearly it was exhibiting that, that how much of the pain manifestation is sort of centrally coordinated. There was nothing there to hurt. And yet he's describing, specifically the fingers and the course of the nerve, da 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 da. And it's like, as I say, like that sort of phantom limb pain. Acupuncturists apparently will treat the other arm and have effect. There are weird sort of psychological things where they do where they have a a mirror put up so you're seeing like a reflection of the arm that you do have and so on and so forth. Um, Something just changed on the computer. Um, but I just found it really fascinating and really enlightening that, the treatment could resolve something. And I think it was less than 6 treatments and it was completely gone. And I said to him, look, I can carry on treating you. There's plenty to do in your spine, yeah. And he goes, no, no, I'm fine. I'm out of here. He'd had this problem for 20 years and it was gone, you know. And it was amazing. Another one was a teenage girl with persistently dislocating shoulder. And one of the things when we were students, Wernham encouraged us to come see him do a talk at the British School of Osteopathy. He'd often gone on about like the BSO, the British school was this, that, and the other, and we thought it was just like politics. So we go to the school, and Mr. Wernham's talking about treating babies with heart conditions, etc., etc. And a lot of the students are there, like with their mouths open, going, "Is this osteopathy he's talking about? Because that's not what we just did." And one of the things that they questioned was like, well, how do you treat hypermobility then? And it's like, well, you treat it physiologically and you treat it relative to, immobility somewhere else, because very often hypermobility goes side
Mm.
by side with immobility. So this girl come in and she'd had a skateboarding accident. So she was going along the skateboard and like they do, she flipped. So she fell really quickly to the floor and it smacked into the back of her cervical dorsal kind of enlargement and her arm as she went back. I think she sort of went to catch herself, strained her shoulder, didn't dislocate it, but strained it significantly enough that the shoulder became progressively more unstable to the point where it was like dislocating. And she'd seen various different people. She'd seen a doctor who'd said sooner or later we'll have to, do an operation to tighten up the ligaments around the GH joint. She'd had physio, and they were trying to do exercises to strengthen the shoulder mechanism. It was just irritating it, etc., etc. And her mum had been having treatment anyway, and she said, can you do anything about this? And as ever, I said, well, I'll have a look. We'll see. I've got no idea. Um, so part of our thinking is about treating physiologically. So there wasn't any relative kind of restriction around it that I could balance out, if you like.
Mm.
But there was a major kind of impaction in the base of the neck, and my only kind of assumption was that was maintaining this problem because of a lack of trophic influence in the structures of the shoulder joint. It wasn't healing. So often when you go back to sort of Still's way of thinking, so often what he was looking for in a patient wasn't what was making them ill. He was looking for what was preventing them getting well. Yeah. Something that I'm trying to sort of do with the Institute sort of courses and the way we teach, try to encourage a sort of different perspective. Still talked about, trying to find the health in an individual rather than just labeling the disease, if you like. So with that in mind, this girl was it was very much concerned with the sort of, as I perceived anyway, the restriction on the base of the neck, the impact, and the way that that had affected the sort of trophic recovery of the shoulder. Um, Worst thing was she was an avid hockey player, and in England that means like, field hockey. Over here in Canada, that means like ice hockey.
Mm.
Um, So I said, look, you need to stop or at least, reduce the amount you're doing because you couldn't imagine anything worse for straining a shoulder than a hockey stick
Mm.
engagement. Anyway, she toned it down. She didn't give it up, but she toned it down enough that the treatment got through and it wasn't a great deal of treatment again. About 4 treatments and it steadied her. And it was again, a really interesting revelation about what osteopathy is and the way it works. Another one was, funnily enough, was her brother. Her brother came in, who was 18 months old, and he had distinctly bowed legs. And they'd done all sorts of tests for rickets and so on, and there was nothing showing up nutritionally. Um, and I had no idea again, I had no idea whether I could do anything. I presumed not, to be honest. And looked really carefully into the low back, and the low back was really significantly impacted and torsioned. I think he'd had some like significant falls as a baby starting to walk around. Whether the mother had twigged or not, I don't know. But I think that that was what was triggering this sort of inappropriate kind of growth pattern that was going on. Anyway, I treated him, undid that pattern, and the legs began to grow straight. Um, Interesting. Very often you don't get a follow-up to these stories, but an interesting follow-up was that I saw him again when he was 18 because I
Mm.
knew the mother, and I treated her at home, and he happened to be there. He'd just been, like so many youngsters do, like backpacking around Asia, and so on. Um, and he, was all kind of achy from carrying the rucksack. So I treated him, and his pelvis was still beautifully level. His lumbar spine was still beautifully articulated and centered. He was just really compressed from carrying a rucksack. And it was like, holy Moses, that process not only undid what was going on with him, but also it left him with the stability and mobility to carry on for the next 16 years without a problem, which
Yeah.
was so those kind of cases are the things that get to me where you don't know you can do anything. You just try, you just follow your principles and Mother Nature sort of, hands it to you on a plate. It's quite astonishing. And it's also like a revelation that, in practice, so often I'll take on, anything that I can, sometimes, if nothing else, to learn about conditions, about patients, and more often than not, I was surprised by what can happen. The only thing is, the sort of caveat with that is so often it's a question of patience, as in like, being patient, not being a patient. Hanging in there, waiting for the results, and persisting, Still and Little John, that they both talked about sort of like, and Wernham, about sort of the lengthy periods you have to wait for kind of responses in patients, sometimes months and months, sometimes years with some conditions to really get to the bottom of something, you know. But,
The body is marvelous. It always
yeah,
reminds me of the body wants to thrive. So if it cannot self-correct, it will just adapt around the lesion point.
as much as possible, yeah, yeah,
So, that little boy potentially could have adapted around that lesion point had you not come in when he had. Had you come in 10 years down the right line, you would have created some sort of balance and harmony, but there'd be tissue memory and adaptive process already
exactly,
in the
exactly.
sequence already that would need more
Yeah.
time to adapt. Had he
It's
come,
like it's like Wenham used to say, with the longer a patient a condition has been around, the more layers there are to sort of peel through.
yeah,
It's not a question of like just doing this bit or that bit or even like all the different bits. It's recognizing that it's a layered process, that each stage, each treatment should be peeling off a layer and introducing something that kind of, functions mechanically and physiologically better to the body. Look, hang on, if you just allow the flow to go this way, or, the restriction in the spine, you just decompress and allow nature to run its course, then, it takes it and runs with it.
Mr. Wernham used to say you can't crack the abnormal to the normal.
Can't adjust the abnormal to the
It
normal.
does. And then Chris Campbell says that each time you treat the patient, they come in with a different lesionology
Yeah,
because of that very principle. You're unraveling the layers of the onion of that
yeah.
patient's physiology to getting them to the point of their ease and health.
Yeah, you drive back towards their primary state, their constitution, and then you adjust the constitution. He talked about that, like, that's where the real work starts. And
Mm,
if you really want to get into sort of like, helping people at a deeper level, the symptomatology is gone. And if a patient really feels the value in the treatment, as in their whole sensorium changes and improves and is more comfortable, then they stick with it.
mm,
I've had patients over the years that have come year in, year out, and still felt a progression in that.
mm.
It's
I
quite
think
amazing.
that is where the magic in osteopathy lies.
Yeah, absolutely.
And it's just so powerful, Chris. When you see it in practice, it's so powerful.
Yeah. Yeah, and like I said, the opportunities you get from your abilities, from, what you're able to see and do. Very often it's like friends, relatives. I've treated my father with pneumonia at one stage, all sorts of different things, kids going through fevers, all sorts of stuff. And it's like always there's the sort of, the principle that we don't want to do any harm. Like
Mm-hmm.
when my daughter had the infantile convulsions, we called the ambulance before I started.
Mm-hmm.
My partner at the time, she screams at me. She was going upstairs, and our eldest was making strange noises like you do when they're going into
Mm-hmm.
convulsion. And, the ambulance was called first, but, I got in there with, and worst case, that kind of interaction is not going to do anything harmful. It's the worst case, it's going to do nothing. You'd have to be really, really stupid and careless to
Yeah.
do anything that would cause, trouble.
The body will take what the body needs.
Yeah,
It's
as
not
long
going
as you offer it in the
to
right kind of measure, the right kind of proportion, as in like pressures and so on, that
amplitude, frequency, all of that.
yeah,
Otherwise, it's just not going to work. And that could be not just in emergency, that's in every treatment.
yes,
If you're coming in at the wrong, God, you've taught me this. You did something very good in one of our lessons once, right? I don't know, I don't think I've ever told you this. When the patient's laying on the table and you're at the patient's feet and you just gently touch a patient's foot, you meet the patient at their level of frequency. If that patient just moves ever so slightly, you go in ever so slightly. If you go in, and I'm a very high energy person for everyone that doesn't know me, if I go in with a patient who's just moved ever so slightly with my energy, they're going to reject my treatment. They're going to, because I've now become a bit of an annoyance to their nervous system, a bit of an overstimulation. They're not going to do well with me, and they probably will never
mm,
come back. And that is one of the most simplest things you can do with every patient is just see where they're at and bring your energy to meet their energy to get in. If you come in too strong, too slow, too quick, too fast, too
it's the,
aggressive,
it's the same with the timing of the process as well, relative to their needs. I mean, so often it's very, very easy to do like a treatment that's too intense, too long, because it's what you want to do. There's still
yeah.
things to be fixed, blah blah blah. Whereas if you're wise up to it, in a sense, it's like the body will only take so much before you're overloading it, either in terms of the nervous stimulus, so you're exhausting a person,
Mm,
or there's just too much for their system to process. And it's
mhm,
kind of like system overload, and then they'll, maybe go into a kind of a bit of a healing crisis, which was unnecessary because
mm,
you pushed a little bit too hard or a bit too long.
mm.
I quite often say to students, really be aware of the timing of treatment relative to the type of patient, the situation, and the intensity of their condition, as it were.
Yeah, that was fantastic. Is there anything you'd like to add before we wrap up?
Uh, I don't know. I mean, other than if people are listening and are interested, the Institute has loads of different materials. There's videos out there, there's lectures out there. I think as an osteopathic organization, we have more stuff going on online than anybody. Plus, of course, the courses that we offer and through other sort of agencies. We work with a group in Italy, we work with a group in Spain. Um, I'm going to be doing stuff here in Canada or have done as well at different stages. Just try and switch into, what's available and or just ask us stuff.
Yeah, you're quite right, Chris. And for anyone who's not on our mailing list, please do go online. It's classical-osteopathy.org and join our mailing list because it's one of the avenues that we use to keep people informed of upcoming webinars, upcoming events. These podcasts go out, and pretty much that. And then we've also got social media as well with the Instagram and WhatsApp, but you're going to get more from the mailing list. than social media because it's all run by volunteers and we do our best.
Yeah, yeah. I mean, that's the bottom line. We put in like thousands of hours of admin and organizing and stuff, and it ain't a paid job, I'm afraid. It's just
Not a
these
paid
people.
job, it's a job of passion. We're paid by passion.
Absolutely. And reward.
Mm,
When you see people, when you've done teaching and you see people, able to help patients in a significant way, like, was the result of what we offer, and you see how rewarding and rewarded,
mm,
they have become as operators. That's the
mm,
value in there. And you know that, you're spreading this wonderful thing.
100%. And you can never hear the same thing enough because you
Mm,
take away something different each time.
absolutely.
It's such a nice learning environment where you're safe to ask questions and fill in the little voids or the concerns that you have. And sometimes it comes across in our podcasts, we fill in those voids. Sometimes it comes across in our events or the webinars that we run. A lot of them are free, some of them paid, some of the donation. Yeah, there's a lot of invaluable content, really.
Yeah, definitely. And the when and if you get involved with the institute, it is a very supportive kind of organization. When
It's
we leave the sort of chat lines open when there's been a WhatsApp like conversation with our student groups, we leave those open, and students, or former students, will come back to us. Oh, I've got a patient with this, that, or the other. What would you advise? Etc., etc., those kind of things, and we're happy, to try and help out, and we do. It's surprising how these conversations kind of roll, and amongst our own colleagues that we offer
Yeah,
support and all that stuff.
that's how accessible our lecturers are.
Yeah, I mean, we're all busy peeps, and I'll very
Yeah.
often have to get someone emailing me a few times before I respond because there's 16,000 emails and spam coming through every day, but that's the way of it.
Chris, thank you so much.
You're very welcome.
A pleasure. So eye-opening. It was so informative. Thank you so much for your time. That was just fantastic.
Let's do more.
Let's do more. Stay tuned for more. Thank you.